Alright, I hope all of you are in good health. There is an increasing trend in the number of people affected by the virus, both in the community as well as inside the hospital, as we see. So try not to step out, but at the same time, work needs to continue. So let us have a discussion on intermediate uveitis and continue the discussion on the uveitis lecture series. So intermediate uveitis is a chronic and a relapsing disease, which means it's a long-term disease with a lot of episodes in between, which show a sudden increase in intensity and a decrease in intensity. And although the name is uveitis, the primary site of inflammation is the vitreous. It is the vitreous jelly which is having the maximum amount of inflammation. So there are other sites that are affected as well. So if you focus on the blue area between the red and the green areas, that is what we'll be discussing today. We've already taken care of anterior uveitis. I'll leave a link at the top of the video just so that you can brush up on anterior uveitis, because a lot of concepts of anterior uveitis are applicable to the other types of uveitis, both intermediate as well as posterior. So anyway, the other sites of affection in intermediate uveitis are the pars plana, and when I say they are affected, that means there is an inflammation there. So although pars plana inflammation means a pars planitis, I will only call it pars planitis if the cause of the intermediate uveitis is idiopathic. For example, if I know that this intermediate uveitis is because of tuberculosis or it is because of sarcoidosis, then I will not call it pars planitis. I will only call it an intermediate uveitis. So the terminology, the specific terminology pars planitis can only be used if the etiology is idiopathic. Other sites are the peripheral retina, because if you go a little more posterior, then the pars plana continues into the retina and the choroid as well because of the anatomical continuity. So the same concept of anterior uveitis, because of anatomical continuity, a lot of the structures get affected together. So 10% of all uveitis cases are intermediate uveitis. The rest 90, most are anterior and a little bit is posterior. But it is more common in children, such that there is a 20% chance that this uveitis is an intermediate one. And the incidence, it peaks in the second as well as the fourth decade. It is not second to fourth, it is second and fourth decade. So a bimodal distribution is said to occur. So what causes intermediate uveitis? It is mostly idiopathic. 85% cases are idiopathic, and there is an association which is seen in these idiopathic cases with HLA-DR2 or HLA-DR15. And sometimes there is a known cause in about 15% of the cases. In a country like India, tuberculosis is very common, so that has to be in one of the differentials when you're considering intermediate uveitis. The other common causes across the world are syphilis, sarcoidosis, Lyme's disease, cat scratch disease. So cat scratch is basically because of Borrelia burgdorferi, and HTLV1, that is human T lymphocytotropic virus 1. So a little bit of a tongue twister. And although not a cause, but a known association is multiple sclerosis with intermediate uveitis. The basic pathology in intermediate uveitis is autoimmune. Very little infective component is seen. Actually, no infective component is seen. It is mostly autoimmune. And to brush up on the pathology, I would again recommend you to go back to the anterior uveitis lecture. So what clinical features will you see? The symptoms are initially unilaterally present. So the patient will notice symptoms in only one eye. But if you examine such a patient, you will find signs in both eyes in almost 80% of the patients. And these signs will usually be asymmetric. One eye will usually be affected more than the other. And usually it is the eye which is showing symptoms that will be worse affected. So what symptoms are we talking about? Firstly, the patient could be asymptomatic. The patient may have come for some other complaint, perhaps a refractive correction which does not improve to 6/6. And then it is discovered that this patient has a chronic intermediate uveitis. However, the most common symptom is floaters. So understand that it is the vitreous that is the primary site of inflammation. So if there is vitritis, which is inflammation in the vitreous is going to alter in its consistency. The normal jelly pattern is going to disintegrate, and there are strands of the vitreous that are going to freely float inside the vitreous, the remaining normal vitreous jelly. So the image on the right side, that is exactly how you see floaters, very commonly seen in the general population as well, especially in high myopics. For the same reason, there is a vitreous degeneration. So floaters are the most common presentation of intermediate uveitis, simply because it is affecting the vitreous. After floaters, the second most common symptom is a diminution of vision, and there is a variety of causes of the diminution of vision. It is not just the vitreous degeneration. You can start right from the lens, which may cause complicated cataract, and go right back up to the retina, which may be causing a cystoid macular edema. So lots of things can go wrong. We'll discuss that in the due course of the lecture. Usually there is no pain, photophobia or redness. So remember, the classical features of acute anterior uveitis were pain, photophobia and redness. So an absence of these symptoms is highly suggestive that it is not an anterior uveitis, it is some other category of uveitis, either intermediate or posterior. And amongst intermediate and posterior, intermediate is the more common one. What signs will you look for in this patient? There will be a very low grade of flare and cells in the anterior chamber, very few keratotic precipitates. As you see in the bottom right image, the keratotic precipitates are placed more peripherally on the cornea, and a complicated cataract. So this complicated cataract may either be because of the inflammatory process which is going on in the vitreous, which is hampering the lens metabolism, or the steroids that we use to treat intermediate uveitis. Both can cause cataract. So steroids, by steroids I mean the systemic steroids, which may cause a cataract. The topical ones usually cause glaucoma. Usually these signs are absent because these are classical features of anterior uveitis again. But because of anatomical continuity, a very low grade of anterior uveitis features may be seen with predominantly an intermediate component. So, it's very difficult to differentiate whether this is completely anterior uveitis or completely intermediate or completely posterior, because the entire uvea is one continuous structure. But usually one section of the uvea is affected more than the rest, and that is why you label this case as an intermediate uveitis, although there may be some low grade anterior component. So usually these signs are absent, hence it is also called a white eye disease, because the eye appears white, there is no redness, there is no congestion. But these signs will be more common in children in whom the immune response is going to be more pronounced, in patients of sarcoidosis and Lyme's disease. Lyme's disease particularly shows a very severe anterior uveitis. We still don't know why, but in Lyme's disease, whenever there is an anterior uveitis, you also have a coexisting intermediate uveitis of a similar intensity, and the reverse is also true. More classically, in intermediate uveitis, you get vitreous cells and vitreous opacity because of the inflammation in the vitreous. So the inflammation may be so severe that it gives rise to a white pupil or leukocoria. This is classically seen as in mature cataracts, or say perhaps a case of retinoblastoma. So there's a differential diagnosis of leukocoria. If you see this in a case whom you're suspecting to be a uveitis case, then it is more likely to be an intermediate uveitis. And this is because the vitreous is undergoing an inflammatory reaction. Because of the inflammation, there is going to be a vitreous haze, and you can grade the severity of the vitreous haze depending on the findings that you see. For example, it is grade 0 if the nerve fiber layer of the retina is clearly seen, grade 1 if the NFL is hazily seen, grade 2 plus if the disc and the vessels around the disc itself, the optic disc itself, and the blood vessels around the vessels appear hazy, grade plus 3 if only the disc is seen, and grade 4 if absolutely no disc is seen. So this is how you grade the severity of the vitreitis. So what is the point of having grade 0? If I can see the NFL, what is the point of grading? So if I say grade 0, it may signify that the patient may previously have been a grade plus 2 who has now shown resolution and come to grade 0. So it signifies that a past inflammatory reaction may have been present, and right now the patient does not have any kind of inflammation. If I do not mention grade 0 at all in my clinical findings, it means that the patient never had vitreous cells and a vitreous opacity in his clinical course. The next sign is snowball opacity. So snowball's opacities are also called ants' eggs. These are nothing but exudates which are present inferiorly at the ora serrata. So why inferiorly? Because of gravity. And why ora serrata? Because that is the area of intermediate uveitis that gets affected. So the bottom left image is most likely an image which is taken on an indirect ophthalmoscope. So indirect ophthalmoscope is that head mounted instrument that we use. So it is, why do I call it indirect? Because the opacities are seen superiorly in the image, whereas they are more commonly present inferiorly. So understand, in an indirect ophthalmoscope, the image is rotated laterally as well as superior inferiorly because of the lens that we use, because of the optics of indirect ophthalmoscope. Whatever I see superiorly is actually present inferiorly. So here in the image, I can see those white dots, very frankly speaking, which are these opacities, which are these exudates that are present. So they are actually present inferiorly, and the bottom pinkish circle that I see, that is actually the optic disc, which is present superiorly. The right side image is a diagrammatic representation of the same. So that is more likely taken on a pan-fundoscope image in which there is no image lateralization and no image inversion. So whatever is inferior will appear inferior. So those are those white dot-like opacities that I see. These are nothing but exudates. Snow banking. So snow banking is the pathognomic feature of intermediate uveitis. So what is the difference between snowballs and snow banking? It is just the manner of aggregation of these exudates that I see. In snowballs, it is like a circular fashion, and in snow banking, it is a deposition in a linear fashion. So it appears as the snow has been deposited along the roadside and in a linear fashion. So snow banking is a pars plana plaque. So what does this plaque constitute of? What does this exudate constitute of? It constitutes of glial cells of the blood vessels of the retina. It constitutes of vascular tissue, because now see, if there are exudates, then the body needs to heal, and to heal, the body tries to produce new blood vessels in the form of neovascularization to reach these exudates, to drain out the exudates that are present, and lymphocytes. So these lymphocytes are predominantly helper T cells category, and these are again best seen on indirect ophthalmoscopy, present inferiorly. So this is how snow banking appears. So the bottom left image most likely taken either on a direct ophthalmoscope or a 90 diopter lens, because the whatever is inferior is appearing inferior. So the snow bank, the white line that you see, the whitish opacities that you see inferiorly, that is the snow banking, and a pictorial representation on the right side. So a short note about the right side image, it is a pan fundoscope image. So pan fundoscope means the entire fundus can be seen. The bright white spot that you see at the center is actually the optic disc. A little to the left of that circular area is the macula. And as the further away you go, you go to the periphery with these deposits present, this snow banking seen at the ora serrata. Okay, neovascularization we've already discussed. So it is basically occurring at the periphery as well as the optic nerve head. It is actually the body's attempt to reduce this inflammatory load that is present in the vitreous. But because of neovascularization, you can have these episodes of vitreous hemorrhage, because understand that the neovascular blood vessels are not normal. They are very friable, they are very weak, so these will bleed very easily with very how shall I call it, trivial trauma. Secondly, retinal detachment can occur, because wherever there is blood vessel, there will be fibrosis, especially when the neovascularization starts regressing. So that is going to cause a traction on the retina and a tractional retinal detachment. And finally, a cyclitic membrane, which means it is a membrane just behind the lens and in front of the vitreous. So the bottom right image is the same as the bottom left image. The difference is the investigation. The left image is basically fundoscopy, and the right is fundus fluorescein angiography. So in FFA, the areas where blood vessels are present will light up, because that is where the contrast will go. So that bright white spot that you see, that signifies neovascularization. You can't exactly see the blood vessels, nor can you see the disc. So this may be labeled as grade 4 vitreous opacity. The next features that you might see if the inflammation is severe enough and progresses to the back of the retina is a cystoid macular edema. And lastly, you could have an epiretinal membrane. So look at the bottom image, the bottom left, the colored image. Try looking at the macula. Usually at the macula there is a bright white spot at the center, which is also called the foveal reflex, because the fovea reflects back light. Here there is no foveal reflex, and that may be because there is an edema at the macula. You can confirm that with the fluorescein angiography on the right side. You can see that there is a diffuse leakage of the dye in and around the macula. So that confirms the cystoid macular edema in this case. Diagnosis of intermediate uveitis is mostly clinical. There are very few investigations that you can do to confirm intermediate uveitis. You can only do them to direct and find out what may be the etiology, similar to anterior uveitis, but it is mostly clinical. So this is one of those diseases where you cannot guess. You have to know the signs and symptoms, you have to know the clinical features, and only then can you arrive at the correct diagnosis. The course of intermediate uveitis is very favorable. About 10% cases show only a single and a self-limiting episode, which means it resolves on its own with or without any medications. And however, 90% of the cases undergo a chronic clinical course. So 30% of such cases will show an exacerbation, one or more exacerbations. So what do I mean by exacerbation? There may be the inflammation is progressing. One fine day, the inflammation may suddenly flare up. There may be a sudden decrease in visual acuity, sudden onset of certain clinical features, and a sudden regression as well. So there are acute exacerbations, so a relapsing remitting pattern. However, most cases will be chronic without an exacerbation. So a low grade chronic inflammation over a period of years is the most common clinical outcome and the most favorable clinical course as well. What complications am I talking about? Very similar to anterior uveitis. Just to short note that the most common type of retinal detachment here will be attractional more than rhegmatogenous, more than exudative. So this tractional RD is because of that neovascular blood vessels that you see. Those blood vessels pull on the retina and produce a traction. That is why tractional is the most common one. Investigation is exactly same as anterior uveitis, except that there is one addition. You are suspecting an association with multiple sclerosis, especially if the patient is 20 to 50 years of age group, which is the bimodal distribution in which the patient falls. And if the patient is a female, then you would suspect MS even more. And so much so that the intermediate uveitis may actually occur before the other symptoms of multiple sclerosis. All of the clinical features may occur later. Intermediate uveitis may be the first thing that you see. So if you see an intermediate uveitis in a patient who is in this age group and is a female, keep in mind that this patient is at an increased risk for developing multiple sclerosis in the future. Treatment, there is a protocol called modified 4-step Capelin protocol. So the 4 steps are basically, the first step is steroid, second step immunosuppressants, third is cryo plus laser, cryo is cryotherapy plus laser photocoagulation, and fourth is PPV, which is sparse planar vitrectomy. So in that sequence, you will proceed and provide treatment. So for the first time the patient comes to me with intermediate uveitis, I will start him on steroids. If the steroids, if the patient is not responsive to the steroids or starts developing complications and side effects, then you proceed to the next step, that is immunosuppressants, so on and so forth, such that PPV is the last step that you will undertake. So steroids, let's talk about steroids first. This is the most common modality that is used across uveitis. So there are 3 modes where steroids can be administered in intermediate uveitis. First and most preferred one is the periocular one, then comes systemic, and the thirdly and the least preferred is the topical route. So periocular are basically in the form of injections in the posterior subtenons region. The preferred drug is triamcinolone acetonide and the dose is 40 mg per week. Depending on the clinical course and the response to the initial doses, 4 to 6 doses may be required for a patient at 2 to 3 weeks interval, because understand you can't keep giving steroids every week. There is a gap that needs to be given. Firstly, because the side effect profile is quite severe with posterior subtenous injections, and secondly, you need to give time to the drug to act on the human eye. So after periocular, the next preferred is systemic, and it is logical to use systemic if the disease is bilateral. So because you can't give steroid injections to both eyes, it is quite risky. You're doubling the risk of complications. So if it's a bilateral disease, you would prefer an IV pulse methylprednisolone therapy, usually 1 to 1.5 grams milligram per kg per day, and which is followed by oral steroid therapy and tapered over a period of time. Topical steroids are used only if there is an anterior component. So for example, if it is a patient of Lyme's disease, you would consider starting topical steroids as well, because those patients show a very severe acute anterior uveitis reaction. Slow release implants are also under investigation, where you implant a slow releasing steroid implant in the vitreous cavity. These are still under investigation, and it will be a couple of years until we are able to use them on a larger scale. And although not a steroid, but tablet Naproxen, which is an NSAID, non-steroidal anti-inflammatory drug, has been shown to be useful in a dose of about 500 milligrams twice daily. So that is how you give a posterior subtenons injection. So not usually preferred if it's a bilateral disease, because understand that twice the number of injections you give, twice the number of complications also that you have to anticipate. So second step, if the steroids are not responsive or the patient start developing complications such as a secondary cataract or starts showing some other complications of systemic steroids, then you start him on immunosuppressants. These are basically steroid sparing agents, and there is no pro forma as to which immunosuppressant you can use. Each patient has a different profile. So, but the commonly used drugs are cyclosporin, azathioprine, methotrexate or cyclophosphamide. The next step, if the immunosuppressants also do not work, or if the inflammation is very severe, it's a grade 4 vitritis which is of a long-standing nature, not expected to respond to either steroids or immunosuppressants, consider cryotherapy. So in cryotherapy, you basically use a probe, this metallic probe, and you place it along, a little away from the limbus, such that it involves the ciliary body, which is lying underneath the sclera. The purpose is, and the other thing that you can do is a laser photocoagulation, and this is especially useful in snow banking, because snow banking occurs only if there is a severe inflammation. So a significantly progressed inflammation. And the purpose behind using either cryo or laser is to reduce the metabolic activity in the ciliary zone. So that is how cryotherapy and laser will help in a case of intermediate uveitis. And if that doesn't work, then directly go to pars plana vitrectomy. So the principle is that vitreous is the primary site of inflammation. So if you remove the vitreous, a part of the vitreous, then firstly the antigen load will reduce, because understand it is an autoimmune response. There is an autoimmune response against the vitreous. So if I remove a part of the vitreous, a part of the antigen is reduced. Secondly, any inflammation that has already occurred, the inflammatory debris, the macrophages, the lymphocytes, those are going to be removed. So again, a second immune response by the body is going to be reduced. And thirdly, the recurrence rate also reduces. So patients have been shown to improve after performing a pars plana vitrectomy. But understand, with both cryotherapy, laser therapy and pars plana vitrectomy, there will be a significant visual morbidity. So this is considered only in patients whom the vision is not expected to improve, in whom the vision has already deteriorated. You will always prefer steroids and immunosuppressants over these two surgical methods. And lastly, not a part of the Caplin's 4-step procedure, but an important aspect in the management of intermediate uveitis is the management of complications. This is pretty much the same as anterior uveitis. Cataract surgery has to be performed because usually there will be a secondary cataract in such patients, which is either due to the steroids that we use or because of the inflammatory process itself. So cataract surgery is performed only after the eye remains quiet for at least a period of 3 months. So that takes care of intermediate uveitis. I hope these lectures are useful. If you love our method of teaching, please give us a follow on Instagram. We keep uploading a lot of content over there. Subscribe to the channel, show some love here, and please let me know which other topics you would like me to cover. Stay indoors, stay safe, good day.